I'm Dr. Brian Hill. I'm the director of the Lymphoid Malignancies Program at the Cleveland Clinic, Towson Cancer Institute, and this is a 2024 year in review for lymphoma. And we're going to talk about a range of topics in DLBCL, follicular, mantle cell, and a little marginal zone, and really be focusing on the immunotherapies, which are CAR T cell therapy and bispecific antibodies, which everyone is very interested in seeing all the emerging data for. So I'm going to start by just reminding the audience that CAR T is here to stay for diffuse large B-cell lymphoma. We have axi-cel, lyso-cel, and tisa-cel. The data for lyso-cel was updated at the most recent ASH meeting. This is from the phase 3 Transform study. This is a large global randomized phase 3 study, which compared standard of care, which was chemotherapy followed by planned auto transplant, compared to CAR T cells with lyso-cel. And this is a 3-year update that was presented at ASH. What we can see in terms of the best overall response rate to lyso-cel was very high, 87%, versus about half or 49% for chemotherapy. And the complete remissions were actually the majority of those responses. We've been seeing a tendency for more and more duration of response curves at meetings rather than PFS curves, which is okay if most people respond, but if not, it's a little bit trickier to interpret. So what we see on this is a DOR curve, which is useful because, again, the responses were relatively high, particularly in the lyso-cel arm. And what you can see is that there is the plateauing going out at 24 to 30 months with about half of the patients still in remission. So this really has been thought of as curative intent treatment for second-line treatment of relapsed large B-cell lymphoma, and is much better than the historical standard of chemotherapy with auto transplant. So there's the sort of not reached medium DOR for the lyso-cel arm. One of the things that many people wonder about is whether persistence of the CAR T product is important or not, and also what the effects are on B cells. And what was nice in the correlative studies from this presentation is that we had data on persistence of lyso-cel by PCR, and what you can see is about a year out that 43% of patients still had detectable CAR Ts. But if you go even out to 3 years, we do see droppage of the B-cell aplasia, which is a common and almost universal part of CAR T cell therapy because the CAR T cells eliminate CD19 B cells. And so as we're using more and more CAR T, we do see some late infections, but it's, I think, reassuring to see that the B-cell aplasia tends to fade with time as the CAR T persistence drops. Moving to bispecifics for DLBCL, this has been a very active area. We have approved agents with epcoritamab on top and glofitamab on bottom on this slide. What's common to both these bispecifics is that they engage CD20 on the target cell and CD3 or T cell receptor on the T cell target, and bring them in proximity. The registrational trials of epcoritamab and glofitamab were a little different. In EPCO, the ramp up of 4 weeks then was followed by weekly dosing for 3 cycles, then every other week for up until cycle 9, and then monthly with treatment until progression or intolerance. So really indefinite treatment. Whereas with glofitamab, there was, again, a ramp up over 3 or 4 weeks, and then the dosing is once every 3 weeks, so every 21 days, and then stoppage at 1 year. You probably could have designed the trials in the reverse order and seen similar outcomes, but this is the way the studies were designed, and these are the way the drugs are approved for either indefinite treatment or stoppage. And so a question really is, do we really know? Do we need to keep treating patients? We think of large B-cell lymphoma as a curative entity, And CAR T cells seem to fade with time. You don't need to keep giving CAR T cells. Do you or do you not need to keep giving bispecific antibodies? So just sort of focus a little bit on EPCO. Again, this is just a generic representation of what bispecific antibodies are do. They're called T cell engaging. Some people call them poor man's CAR T cells. The data for epcoritamab was shown with a 3-year update for the NHL-1 study. This is the registrational trial that led to approval of EPCO for third-line plus relapsed refractory DLBCL. This is a single-arm study. This is a heavily pretreated group of patients with a median of 3 prior lines of therapy. Many patients had prior CAR T cells therapy, as you can see, about 40%. And if we look at, again, PFS long-term, this is sort of an elongated PFS curve, but it does show a pretty favorable 30-month PFS time point of about 70 to 80% for most populations. This is large B-cell lymphoma. And these are the, again, complete responders. And so this is something that we think of as being, very durable benefit for particularly for patients who had complete response. And so the question is, in this schematic that was presented at the meeting, on the right here, we can see that of the patients who continued treatment beyond 12 months, there was only 5 of the 47 who had relapsed between month 12 and 24, and then beyond 24 months, there was 29 patients, and only 2 of them have had progressive disease. So this seems to speak to the potential for durable ongoing remissions in the majority of patients. I will say that there's some concern about infections that can crop up with continuing long-lasting B-cell depletion that accompanies bispecific antibody therapy. And I think more data will be needed as we go forward to watch out for this. If we shift and look at glofitamab, again, similar mechanism of action, slightly different structure, as I showed earlier. The long-term follow-up was also presented recently. This is 3-year data from the registrational trial of glofitamab, and this is just showing the schematic with the ramp up. There is a day 1 dose of obinutuzumab to deplete B cells, and then step up dosing over the next 3 weeks before reaching target dose. And what you can see here on the PFS and overall survival curves for the glofitamab is that we again have, if you look at sort of a landmark here at 1 year, this is when the treatment stopped. So you have about 80% of patients who have not progressed at 1 year. And then if you look sort of at what happens over the next year, we have a little bit of a drop off, is 20% roughly. Again, excellent overall survival for the patients who get into complete remission. But I think, we don't quite know yet whether this is a significant difference between the 2 trials, and whether or not continuous treatment is needed, or if maybe we should do some sort of response-adapted continuation of treatment based on response or MRD, for instance. One of the benefits of discontinuing B-cell depleting therapy is that you recover your B cells. So as you can see, starting right around 12 months, which is the time point when the glofitamab was discontinued, you have recovery of B cells, and your immunoglobulin levels sort of dipped and recovered, although those are not highly significant differences. I think that probably discontinuing treatment is going to lead to better immune reconstitution over time. So because of the recent approvals of these, we were quite interested. There's a lot of interest in combining bispecifics with traditional cytotoxic chemotherapy, particularly because for a highly aggressive disease like relapsed large B-cell lymphoma, many patients have early progression during the ramp-up phase, which takes about a month. And during that time, patients are really getting somewhat suboptimally dosed with the active agent. And so this was the so-called STARGLOW trial, which was recently published in Lancet. This is a large global randomized phase 3 trial of chemotherapy with GemOx with or without glofitamab. And the red curve here shows the PFS on the left and overall survival on the right, greatly favoring the addition of glofitamab to GemOx. And this is done largely in countries that didn't have CAR T cells, so very few patients went on to get CAR T cell therapy. And so this sort of suggests that a strategy of using bispecifics with chemotherapy may kind of get the best of both worlds for immediate disease control, followed by long-term immune effector cell engagement, which may, with longer time points, we may see that whether or not these plateaus in the curve hold up, and maybe we can sort of cure patients with a chemotherapy bispecific approach rather than relying on CAR T, which is, of course, cumbersome and not available at all centers. So we were quite interested in this topic of the different bispecifics, and we put together with 20 U.S. Academic medical centers something we call RealBite, which is real-world outcomes of bispecific T-cell engaging therapies. And we were able to collect data on over 200 patients treated at the multiple centers. And without belaboring the details too much, what we did see is, not surprisingly, the progression-free survival of patients who would have been likely eligible for the clinical trials was much better than these patients in the real world who did not fulfill eligibility. And this is something we've seen time and time again with real-world data, is that that clinical trial eligible patients tend to do better than those who are not due to comorbidities or other factors. But another story, which I think is really important to highlight, is that the studies that led to approval required CD20 expression. And as we know in lymphomas, as you get treated with rituximab-containing chemotherapy, CD20 loss is a pretty well-described phenomenon. We identified a number of patients who, at the pre-treatment biopsy with bispecific, actually had already lost CD20. And what we can see is a major difference in the outcomes based on CD20 status. So I think this does need to be on the radar screen for clinicians as they're thinking about using bispecifics to make sure that the antigen is still present. And then we did have a number of patients who had a known TP53 mutation. And when we compared those with wild type or unknown p53, there was really overlapping curves, which seems to suggest that, unlike chemotherapy, the bispecifics can work very well in those with TP53 mutations. And there's the CD20. So let's kind of move on from large B-cell lymphoma to follicular lymphoma. Again, it's a similar theme here, that we have cellular therapy and immune-engaging T-cell bispecific antibodies. So we'll start with CAR T for follicular lymphoma. This is a crowded space. There's 3 agents that are used, but I'll start with Lysocell. This is the Transcend FL study, which was presented in updated form with 2-year follow-up. And the outcomes or the study design was patients with high risk relapsed refractory follicular lymphoma. Most of the patients were in the 3rd line setting, as you can see on the right, 114 of the 139. But there were a small number of patients who had high risk of follicular lymphoma in 2nd line, including those with POD 24. So that's early progression within 24 months of frontline therapy. And here are the outcomes. So we have on the left duration of response, PFS in the middle, overall survival on the right. And you can see very favorable outcomes. I mean, the overall survival is really phenomenal. If you really focus in the middle at PFS, what I would say is that, not surprisingly, the 3rd line patients tended to have slightly worse outcomes, as you can see in the sort of orange curve, compared to those who had 2nd line treatment. And so there's an ongoing expansion cohort of this study targeting the POD 24 patients to see if this may be the solution for these patients, which historically have had very poor survival and outcomes. T-cell is, the maybe less spoken about CAR T product, but it does have an approval in follicular lymphoma. I'll just show kind of briefly the Alera trial, again, single-arm phase 2 trial, as most of these CAR T studies are. And we do have pretty long follow-up shown here. Again, maybe focus on the middle, which is the purple curve. This is the progression-free survival. And if you kind of look out at 24 months or so, the plateau on the curve looks, pretty good. But if you look at about 30 months out, 60% of patients, maybe a little bit lower than with liso-cel, but relatively low rates of cytokine release syndrome and low rates of neurotoxicity with T-cell. And then, the third CAR T product that is used probably much more for large B-cell lymphoma, but does have an approval for follicular, is Axi-cel. Again, this is targeting CD19, as all the other CAR T cells are. And what we can see is that the PFS with follicular lymphoma and some marginal zone lymphoma patients plateauing right around 50%. This is independent of the high-risk features, including POD24. So I think that, it's a crowded space right now, and we have a few different agents. The toxicity profile of Axi-cel tends to be a little more on the CRS and neurotoxicity arm. So if you have older, frailer patients, many would prefer one of the other products, liso-cel or T-cell. But in the case of really aggressive follicular lymphoma that's sort of behaving like a transformed disease, and you have a young patient, Axi-cel may be a good option. And then staying within the follicular lymphoma space, we'll jump back to the bispecifics. Again, mosunetuzumab is the third bispecific that's approved for lymphoma, but it was actually the third one we've talked about. It was actually came before the others in terms of their approval. It's currently approved for third-line treatment of follicular lymphoma. And what we can see in sort of some long-term data for follicular lymphoma is in this single-arm study, plateaus on the curve right around 50%, including pretty high-risk patients. So I think that mosunetuzumab is a good option, but we do have a lot of other things that we can do for patients in the kind of relapse space for third-line plus follicular lymphoma. Not to belabor the point, but we do now have another approval of a bispecific for third-line plus follicular lymphoma. This is epcoritamab. This one should sound familiar from earlier because its first approval was for large B-cell lymphoma, but it does now have an approval for follicular lymphoma. What we can see in the EPCOR NHL-1 study is that for patients with relapsed refractory follicular lymphoma, again, PFS on the left plateauing around 50%, and it's, again, a huge difference with the durations of response with those who got a CR being very favorable. At 2 years, you're looking at upwards of 60 or 70% with of those who got a CR, and people who did not respond or had a partial response tend to have a rapid drop off. The nice thing here was that the EPCOR study did include MRD status. And in this case, we do have a pretty big difference between those who did or did not achieve MRD undetectable state. So it's suggesting that end of treatment MRD is probably very prognostic of, long-term PFS. And then, in the kind of last bit of the section here, we'll focus on mantle cell lymphoma. Continue with the theme. We have both CAR T and bispecifics now emerging as an option. We'll start with liso-cel for mantle cell lymphoma. This was the Transcend NHL-1 study. Final results of the registrational trial for liso-cel. This is presented at the ASTCT Tandem meeting this winter of 2025. So the study, again, was a single-arm phase 2 with about almost 90 patients. But you can see here, heavily pretreated patients, 30% had 5 or more prior lines of therapy. Almost everyone had a prior BTK inhibitor. The majority of those were refractory to the BTK inhibitor, and about a quarter were TP53 mutated. So lots of sort of high-risk features in this group. And what you can see is incredible overall response rate of 83%, 72% CRs. And again, the famous DOR curve on the right showing patients who respond tend to have pretty durable response, maybe not quite as good in mantle cell as what we see in diffuse large B-cell lymphoma. Anecdotally, I think we do sometimes see later relapse off of CAR T for mantle cell, and that might be what you're seeing here with a little bit more suggestion of a droppage, even for those who achieve complete remission. One of the unique things about liso-cel compared to, let's say, Brexu-cel, which is the first approval CAR T product for mantle cell, is that the rates of cytokine release syndrome are only 1% grade 3 or greater. And the neurotoxicity, although about a third of patients have some neurotoxicity, it's only about less than 10% of high grade. So you still have the potential for infections, hematologic toxicities, and so forth. So CAR T is still, I don't think, for the faint of heart, but for reasonably fit patients in their 60s and 70s, I think that liso-cel is a welcome addition to what we have currently. And then if we kind of look a little bit towards the future, which is almost here for mantle cell, we've going back to the bispecific era. And so we have a registrational trial that we don't have an approval yet for, but likely will, or I would imagine will be considered in the near future, which is glofitamab for relapsed refractory mantle cell lymphoma. Again, in a heavily pretreated patient population, you're getting some reasonable disease control, around 40% for heavily pretreated patients. So I think that the introduction or eventual approval of bispecifics for mantle cell will be a welcome addition, because other than chemotherapy and BTK inhibitors, really the only thing we have is CAR T in that kind of third line space, and patients often exhaust all of those treatment options. So looking to the future, it's always a little tricky to cover things that are not yet approved, but maybe on the horizon. When we talk about marginal zone lymphoma, it seems like even though it's a rare entity, there's always drugs that are chasing this diagnosis. We don't have public results, but there has been a press release from top-line results of liso-cel in adult patients with relapsed refractory marginal zone lymphoma. These patients can burn through treatments, and particularly for young patients who've had things like R-CHOP and BTK inhibitors. Right now, there is no approved CAR T-cell therapy for marginal zone lymphoma. And so having something maybe later this year that could be approved would be welcome. So would anticipate that this will be something that will be presented at a summer meeting near you. And then in the last couple minutes, maybe sort of looking further down into the future, these are not approved, but one I think was worth highlighting, which is still in the same sort of class of agents that we've been talking about, which is immunotherapies. So this is called AZD0486. This is again, a bispecific T-cell engaging bispecific antibody that targets CD19, which is different from all of the approved bispecific agents that we've been talking about today, which are all targeting CD20. And as I showed, if you don't have CD20, your bispecific targeting CD20 probably won't work. So this is a first-in-human study with a step-up dosing, which has been done to mitigate cytokine release syndrome. And what you can see in this single arm is that they have to start at low doses, 2.4, 7.2, then 15 milligrams. And in a patient population with heavily pretreated diffuse large B-cell lymphoma, with half the patients having 4 or more prior lines of therapy, and about 60% having prior CD19-directed CAR T-cell therapy, we actually see very promising clinical activity. If you look overall at all the patients, the response rate across different dose levels was up to 50% at the highest dose level, with most of those being complete remissions. And there was also an arm for follicular lymphoma, again, heavily pretreated follicular lymphoma in this cohort, 20% bulky disease, a third of them with POD24, 60% with 3 or more prior lines of therapy. Many of them had prior CAR T, or some of them, I should say, had prior CAR T or CD20 T-cell engaging therapy. And what you can see in the waterfall plot is pretty remarkable. So really just dropping off the sum of the product of the tumor diameter. Overall response rate 95% with a CR rate of 85%. So pretty impressive. And the rates of adverse events and neurotoxicity were pretty minimal, pretty manageable with step-up dosing. And so I think looking to the future, this type of approach where you have different CARs and different bispecifics targeting different antigens is going to be really exciting to see what happens with this agent in the future.